talking about hospital-based research, and then Mr. Adedeji will follow on with audits and collaborations. I will attempt to share my screen. Is that showing okay?
Yep. Yes, it is.
Yes,
okay,
sir.
So that's brilliant. So, yeah, this is under the umbrella of the Ibadan Medical Specialist Group, as you know, and I'll be talking to you about hospital-based research. Now, the outline of the talk, I'll talk to you about general guidelines around what makes for good research. I'll talk about the different research methods and different study types. And at the end, we'll talk about sort of different practical examples, and I'll be keen to hear your thoughts on how you would handle different research questions as well. I quickly want to say that myself and Mr. Adedeji wrote a book chapter on guidelines, methods, and study types for the Ibadan Medical Specialist Group. So that's already available on the Moodle webpage. So please have a look, because a lot of what we'll be chatting about today is already in print. So guidelines on good research practice. So I want to hear from you first. What is research? I've started with a very low level, easy peasy question. Anyone, what is research? Anyone?
I think that obviously to help along, if you want to answer questions, put up your video, raise your hand so we can have a look, so you can answer the questions. Otherwise, Mr. Olaleye will just pick on anybody.
And I can see all your names beautifully put on your screens.
Okay, and there is there's somebody, Alabi Popola.
Okay, go ahead.
So yes, thank you. Research is a scientific process in a bid to answer a question. That's the way I can put it. It's a scientific process that is scientifically sound in order to answer a question.
Yeah, absolutely. I agree with you. You're correct. So yeah, so essentially research, you go through research. It's a systematic investigation into materials and sources. It helps you to establish facts. It helps you to reach new conclusions. The systematic inquiry is intended to describe, to explain, to predict, and control the observed phenomena. There are different types of research. It can be exploratory, it can be descriptive, it can be causal. The purpose of research really is to enhance society. It helps to advance the knowledge that we have. You develop scientific theories, you fill the gaps, you come up with new concepts and new ideas, essentially better ways of doing things and better ways of medicine, evidence-based medicine. Research is concerned with creation of new knowledge or using existing knowledge in a new and creative way. And that can then cause you to generate further new concepts, methodologies, and understandings. As far as you're concerned, it helps you to find better treatments for your patients, and it should really concern you as surgeons. It helps you to fill in the gaps. It helps you to practice evidence-based medicine. Why do you do what you do? What's the basis for the approach you've used to operate on that patient? Research helps you to answer a lot of those questions. So I think it's absolutely integral to everyone's practice. Now, research excellence and integrity. Integrity is very, very important when it comes to research. You have to abide by international set standards. patients have to, or participants have to know what your planned intervention is, know what the alternatives are, know what the risks are. They have to be, they have to have capacity to consent to participating on your study. They can withdraw their consent without any explanations. And it has to be above board. So integrity is at the heart of research. Because you want the scientific community to trust your results when we can see that it's been done in a systematic fashion. It is repeatable. We can find your data. We can corroborate your data. We can validate it in a different population. And so integrity is absolutely important. Now, respect for patients, respect for your colleagues, respect for the process. Respect for multidisciplinary teams that work on research is important. Ethics, I've put that in bold there. Now, it feeds back into what I was initially saying. Previously, before we had all the Nuremberg codes and WHO standards and guidelines on how to, on the professional standards on research, there were some absolutely horrid things that happened in research. And one of the ones I'll talk about is the Tuskegee syphilis study, which was done on African Americans in the US. And essentially it was looking at the natural history of syphilis in African Americans. It was unethical because by the time they discovered the treatment for syphilis, penicillin, they still didn't give the participants the drug, and they just waited to see what happened to them, what syphilis did to their end organs and their brain and the sort of mortality. Okay, fine, he gave us answers to what happens in untreated syphilis, but my God, that was unethical at the highest levels. Until today, the African Americans still point to that study as a reason why they do not trust the government. And I fully understand, and the reason why they don't trust any vaccines or anything coming out of the government's mouth, because we weren't open with people. They weren't honest with people, and there are lots of other unethical studies all over the place, but that is particularly poignant. It's important to be honest and transparent about what you hope to gain from the research. Sometimes patients want to know what's in it for them, and if there's nothing that they will gain, you should say that and say, well, you may not benefit from this, but the next patients that come may benefit from the use of this drug. And it's important to be open and accountable. You should have rigorous audit trails in place for how the data was generated, missing data, your attrition rates. It should be all documented. And we should support training and skills in research. We should collaborate. Mr. Adedeji is going to talk about collaboration because it multi-center, multiple specialists doing work together. We're able to get to the answers quicker. Public engagement is also a very important one, and it's come to the fore in recent times. And I put that there because you do need to recognize that right at the planning stage for whatever research you want to do, you need to think, how can we involve the end users? How can I involve the public in this research? What is the opinion of the patient or patients who will use this service or take this drug or undergo this surgical treatment? There are patient groups that you can approach, or at least just give them questionnaires to say, hey, we're planning to start doing laparoscopic surgery as opposed to open surgery in a certain DGH close to you. What do you think about access to it? What do you think about the service itself? Is it representative, or is it in a high socioeconomic place that deprives a section of the community? It's important to build in patient engagement. And in fact, there are now patient-led research studies where you get patient involvement as authors as well. So those are sort of the guidelines around good research practice, the ethics, the consent. And you're all surgeons, you're aware of the word consent. The participants have to have capacity. You want to be careful not to include vulnerable adults. or people who may not fully, and when we talk about capacity, the ability to understand the proposed research or procedure, to retain the information, to repeat the information to you, to understand what the risks are, what the benefits are. You've told them what the alternatives are. And even if they do refuse to join your research, their treatment is not hindered because they're not on your research. You still treat them equitably as you would anyone else who was part of your research. Levels of evidence. It's important to talk about this and the various studies because it helps your evidence-based medicine. This is how we practice medicine. It's a hierarchical nature from low-level evidence to high-level evidence, from expert opinions. The professor in your department has said, this is how we do it because I've done it like this for the last 50 years. That's an expert opinion. It is a level of evidence, but it is a low level of evidence. Then you come on to case reports. You see something exciting in UCH. There's a big tumor from the neck associated with another tumor in the kidney that causes blood clots or whatever it is. You put it out you publish it, and you find that there are 2 or 3 other cases around the world that have ever been reported. Suddenly you have a case series, and when you bring that together, we begin to see a pattern. One of the key things about research is you're inquisitive. You want to find, you're observant about unusual phenomena. You keep asking the question, why has this patient got this condition? Or why is this disease in the community? It's important to be inquisitive. And that will lead you to the answers, to finding the right questions and the right answers. Then you have case control studies, which I'll talk a little bit more about. Cases are, people who share a certain characteristic or, a condition, like lung cancer, for example. And controls are people who don't have that condition but are exposed potentially to a certain independent risk, like smoking. And you can then look at what the outcome measure would be, whether it's chronic bronchitis or whether it's lung cancer. Case control studies are quite good for rare conditions, and you can go forwards or backwards, prospectively or retrospectively. Next up the ladder are cohort studies, where patients are followed up over time. And if you think about, let's think about bread for example. I'll use bread as an example. So I know some of you like agege bread, so I wouldn't use agege bread. I'll talk about sliced bread. So if you think about sliced bread, when you slice, one single slice is a cross-sectional study. What is happening at a specific time point? In 2021, on this specific day, we sampled 100 residents. And this was the proportion that had X. That's a cross-sectional study. When you then put in time, when you start following people up and you repeat that study every 5 years or every 10 years, suddenly that sliced bread is no longer one slice, it's now several slices, and that's a cohort study. Okay, and that gives you a lot more information. Randomized controlled trials, these are your high level evidence trials where you begin to you try and minimize bias between arms. You make sure the patients are age and sex matched and variable matched as much as possible. And we tend to use this to look at interventions for drugs and therapies. And we give one arm a placebo or nothing, and we give the other arm the treatment. And then we can say conclusively whether or not the drug or intervention works. Then we start looking at systematic reviews, and high up the ladder are meta-analysis of systematic reviews. So systematic reviews, you bring all the evidence together that has been published in literature in a very controlled, prescriptive process, and you have predetermined endpoints. You don't chop and change in between. You publish your results, and everyone can then say, yeah, we looked at 50 studies that have said laparoscopic surgery will reduce length of hospital stay. And the meta-analysis is right at the top. May I ask us all to mute, please? So I'll ask us to all mute, please. I don't know if I can do it from my end.
I'm trying to do that now. If I do that, it will probably mute you as well. You can mute yourself.
Yes, I will mute myself. So I'll okay, I'll just carry on. So research methods, they can be descriptive. So surveys, cross-sectional studies, which we've talked about, qualitative studies, which tell you the reason why. Qualitative studies tend to explore why people behave the way they do, qualitative studies, if you get smokers, for example, a qualitative study would involve, focus group discussions where you sit down with a couple of smokers and they can fill questionnaires, you can chat to them about why they do what they do. And suddenly you have a different set of answers about why they smoke. It's cheap, it relieves stress. Everyone in my family has always smoked. I just find it comforting, and then you get a bit of an insight into why they do what they do. So qualitative studies are quite helpful. Case reports, as we talked about, and case series, the low level of evidence. However, they do provide insights, particularly in surgery, where you can have unusual conditions. Analytic data to try and understand correlations. Experimental studies like randomized controlled trials, and observational studies. We've talked about cohort studies where you follow people up over a time period, and you sample that population at each time interval for your outcome measure. Case control studies, patients who have a condition and patients who don't have a condition, and you predetermine what the endpoint will be. For example, lung cancer, which we've talked about, and patients who smoke and patients who don't, and you can look back from either look back from patients who have lung cancer and look back over time to their smoking history, or you go forwards prospectively from patients who smoke and who don't smoke, and go forwards, follow them up until they develop the endpoint. Prospective case control studies are obviously stronger because they minimize confounding, they reduce the risk of bias, and you can pre-describe your outcome measure. Cross-sectional studies, we've said, is a point in time measure, a single series of 1,000 people, and you tested them for something as a cross-sectional study. So again, this is just to go over the research studies that we've talked about, and I will just talk a little bit about and give you a couple examples just so that it sticks. So we've said cohort studies. So now one of the very famous cohort studies that we have is the cohort study done by Dole and Hill in 1951. This was one of the first studies that gave us very strong data supporting smoking as causal for lung cancers and lots of other respiratory conditions. And essentially they sent out questionnaires to doctors in the UK. It's a cohort study that ran for about 50 years, and you can see you will get a lot of data that way. They contacted doctors on the British Medical Register. They excluded females and people less than 35 years old. They sent out about 34,000 questionnaires, and And they looked at the cause of death in the registers subsequently. How many of these 34,000 were still alive in 5 years, 10 years, 20 years, 50 years? And how many of them smoked? And how many of them developed lung cancer or chronic bronchitis or cardiorespiratory conditions? So those were the outcome measures. 50 years of follow-up. So in the first 10 years, there were about 4,600 deaths. Straight away, people started talking about an association with lung cancer from it. And at 20 years, there were 10,000 deaths. And not only did they see lung cancer in patients who smoked more than 35 cigarettes per day, and they saw chronic bronchitis, they saw cardiorespiratory issues, pulmonary TB, peptic ulcers, and that became a very, very strong data point for smoking cessation campaigns. What we also saw was that when smoking levels started to drop, lung cancer rates started to drop, and they followed these patients up for 50 years. So that's a cohort study. It is expensive if you're going to do that sort of thing. I need to be aware that you could have dropouts. In this case, they were all doctors, so they were easy to follow up. You could find where people were because they had to register with the General Medical Council every year. And because they were physicians, they likely had access to high level of care, and therefore it was easier to get a cause of death recorded for them. But it might not be the case in other cohort studies, so you need to be aware of attrition. Cross-sectional studies are studies at a time point, and case control studies we've talked about. Similar lung cancer case, you can try and identify risk for bowel cancer, for example. If you wanted to find an association between bowel cancer and a particular diet in Ibadan, you could, because case control studies can look at rare conditions. You could go from the registry in UCH and say how many patients have bowel cancer recorded over the last 20 years. And of these patients who've had bowel cancers, those will be the cases. How many patients were seen in UCH in the 20 years who were same age and sex matched and comorbidities matched? You have your controls. Then you go back into the history and try and find out how many of them had this particular diet that you're interested in, whatever it is, and try and find it that way. You will struggle because you might find that data is not readily captured, and that is a big Achilles heel for retrospective studies. But if you wanted to go forwards, you could prescribe what data points you want to collect over several years. Qualitative studies we've talked about. It gives you an insight into why patients do what they do. Randomized control trials are also they're quite good for interventional studies, looking at interventions or whether you give someone a drug or chemotherapy or surgery compared to people who you don't. The key here is that you randomize the patients to minimize bias, their age and sex matched or comorbidities matched as much as possible, so that we know that the effect that we're measuring is directly attributable to the drug or the intervention. Systematic reviews are high-level evidence that you all can get involved with, whether as individuals or as a collaborative. You need to define your question well, and I'll talk about PCOS, way to define your patients, intervention, what you want to compare it with, what your outcomes are. You need at least 2 people to do a systematic review, and a third person to be a judge for when you refuse, when there's disagreement between what study to include or not, and then you report your data. When you pick up several systematic reviews together, it becomes stronger, it becomes a meta-analysis, and you can get a statistician to help you with that. I talked about, so to define your research question, I find this quite helpful. High cost, so your P is your patient or population. Who are you interested in? Is it the bowel cancer patient who is male, who lives in Bere, or is it the breast cancer member of staff who are nurses. What's your patient population? What's the intervention? You have to say what it is. Is it surgery versus nothing? Is it surgery versus radiotherapy? Is it surgery versus placebo or a drug? You need to define what you're comparing it to. You need to define what your outcomes are. You're looking for pain control, length of hospital stay, survival at 2 years, survival at 5 years. You're looking for bleeding risk, whatever it is. You need to define your outcomes. And then you now need to think about what study type best answers the question that you have. If it's effectiveness of a drug, then you want to look at a randomized control trial. If it is an effect size from an exposure, if you want to compare an exposure and an outcome, you might want to look at cases and a control, so a case control, for example. And if you just want to find a specific thing that surgeons across the world are using for a particular type of surgery or patient group, then you could do a systematic review. This is all very important because it lends itself to evidence-based medicine, which you should all aim to practice. You might be doing your procedures using a certain type of suture or a certain type of technique, and there's new evidence that a different way works. You want to look at the papers that have been published, and you want to try and understand how they reach their conclusions. It helps you to formulate your own research questions, and for systematic reviews, it helps you to fine-tune your questions so you don't end up with an unrealistic systematic review where you've just got a nebulous, very open-ended, I just want to find the cure for every condition sort of question. You want to really, really narrow it down. And if you use PICOS, it does help. If you're looking at observational studies, there are lots of different guidelines that you can use to report your studies. And at least if you know what those guidelines are de novo, you can then plan to respond to, you can plan to provide answers to all those variables. It's the title, the introduction, background, objectives. These are things you already know. And the methods, what sort of study design is it? What setting is it? Who are the participants? What are the variables you're interested in? In terms of the data, is there any inherent bias? If it's a survey, for example, have people forgotten? What's your study size? With study size, you might need a statistician to help you calculate the sample size that will give the effect size that you need. What quantitative variables what methods are you what statistical methods are you going to use? If you're comparing continuous data, if you're comparing means, are you going to be using the mean test for continuous data? Are you going to be using Fisher's test? What sort of test are you going to use? Are you comparing categorical data with a chi-square test? Or are you comparing correlated data where those two variables can be codependent, like, for example, weight and BMI, for example. Those things are correlated data. So you need to think about what sort of stats you want, and you can get advice on that. You want to think about matching and any other sensitivity analysis. And you need to report your results like everyone else. How many patients were in your study? How many patients did you lose from your study? What were their demographics? And in the discussion, it's always a good idea to talk about the results, what your limitations were. It's a retrospective study. We lost a lot of patients in this survey. How have you interpreted the study on the background of current data, current research? Is it generalizable? The fact that it's common in Ibadan, does that mean it's common in London, for example? Is it because the goiters in Ibadan are because of iodine deficiency compared to somewhere else? So you need to think about that. And you need to be explicit on where you got your funding from, if you did have funding, and because it lends credence to your results, and people don't say, well, he collected money from XYZ. This is another sort of reporting guideline for systematic reviews. It's called the PRISMA flow diagram. It's for If you follow it, it's quite easy, and this is readily available. You just need to put in the numbers of patients in the boxes. You identify, you predetermine your question. You do your literature search through PubMed, Medline, Embase, whatever it is there. You record you record your keywords. You put it into it. It spits out a number of abstracts. You look through the abstracts and you put it against your eligibility criteria for your study and say, what I'm interested in is patients who have lung cancer. And then you write how many abstracts say that. If there are duplicates, you pick up duplicates. When you screen, you write the numbers of duplicates, you take them out. I would suggest that you use a program like EndNote, which I used, or any other program that works for you, because you'll be dealing with if you're dealing with large numbers of abstracts, it's easier to just read the abstracts in EndNote and then put it in a column for the ones you want. So you go through identification of your studies, you go through screening of the ones that don't meet your preset eligibility guidelines. So you go through the eligibility criteria as well. You include your studies, and your studies don't all have to fit into a quantitative analysis. It might be more descriptive, qualitative things as to why people do what they do, and you could do that in a subset analysis. And right at the end, you tell us how many studies were included. So you could start with over 1,000 studies in your initial search and end up with just 45 studies that you can include in a meta-analysis. So it's important to see every step of the way how many studies go from identification, screening, eligibility, and inclusion. I was going to show this because this is for randomized controlled trials, or the CONSORT flow diagram, it's called. And again, patients get enrolled, you need to assess them for eligibility. You exclude patients who don't meet that criteria. And there's a concept of randomization. This is to try and reduce bias, or putting one patient in the surgical arm because is your cousin's friend. It can be done by a computer-generated algorithm, or it can be done, sequential patients. But it just means that you don't have control. You're blinded to what treatment the patient may be allocated to. You may not be blinded to the surgeon. And then you've got two arms, the intervention arm and the placebo arm. They're age and sex matched, and then you can say whether the drug or intervention works. You need to follow patients up to see what the side effects were, to document their survival, their overall survival, their disease-specific survival at 2 years, at 5 years. You need to document any side effects patients had from your intervention, or surgery, bleeding, death, need for readmissions, or cancer recurrence, or things like that. You document all that, and then you analyze your data and you report it. Now, I'm just going to talk just about a couple of practical examples before I finish. Now, I really do want you to develop an inquisitive mind. That's where you start off with research. There's a lot around you in Ibadan that need answers. Think about the cholera outbreak in the 1950s. Think about John Snow. And what he did was, there was a cholera outbreak in Soho. And he started plotting the cases of cholera on a map of the area. Trying to find out the geography of, where do people live who are coming down with cholera, and eventually identify that it was from a water pump in Broad Street. And the government then closed down the water pump in Broad Street because that was the source of the disease. Now, at the time John Snow did this, it went against the overriding theory of disease at the time. It's called the miasma theory, which essentially was that disease is caused by bad airs or vapors entering the human body. So you can imagine how unpopular it is for a scientist to want to say, no, it's not the air or vapor, it's an organism in the water. So you should have the strength of conviction to observe phenomena and try and pin it down. And that really helped stop the cholera outbreak. Think about smoking and lung cancer. We've talked about the Doll and Hill study in over 30,000 doctors in the UK, followed up for 50 years. That's how we know it causes lung cancer. And think about, anti-malarial drugs. Do they work compared to what intervention, all the mosquito nets or insecticides, and what are the side effects. And think about the COVID pandemic. We're currently in a pandemic, and there's so much going on that you can do in terms of describing, even if it's just a descriptive study on the COVID affectation in Ibadan. Who is getting COVID? Are they mainly young? Is it 80% mild or asymptomatic disease as we see in the West? Who are the people getting severe disease or hospitalized? Who is needing a tracheostomy? What is the outcome of severe disease? Is there any impact on ethnicity? Are the Yorubas doing better than if a Hausa man gets COVID? I mean, there's so much to think about. And think about the public health impacts of the vaccination itself. Can we reduce the caseload? Can we reduce hospital admissions or mortality? Or the impact even on your training? So there's a lot going on around you. You just need to be keen and inquisitive and go to where the data is. As surgeons, you can go to retrospective reviews of hospital records because that is a low-lying fruit. Records may not be properly kept, they may not be electronically held there, and those will be the problems you may have. But the records might be there. You might have multiple surgeon series, single surgeon series of a particular procedure that's been done in Ibadan, and you can retrospectively review the thyroidectomies that have been done for whatever, thyroid cancer or goiter, and look at the outcomes of laryngeal nerve weakness or airway compromise. I mean, you can look at the bowel cancer cases, you can look at breast cancers and look at whether there was any genetic testing, whether there's any family histories, and you can publish. These are publishable, but you do need to go from retrospective to prospective studies and set this up, and you could do that in a collaborative, which Mr. Adedeji is going to talk about in a minute. I've put the research practice principles and guidelines for General Medical Council and the Medical Research Councils up there, and that's the paper referencing the DOL study. In conclusion, I want to say that there are certain components for research that I have found in my experience, working like you at your stage as a resident, needing to do research or audits and publish maybe 1 or 2 papers a year. I've done a PhD as well, so I can tell you that you need a clear research question. You can't save the world. You're not going to answer all the questions. You need to pick a very clear question. Make sure it's realistic, it's achievable, it's time-bound. You don't have, your resources are not infinite. Pick a question that you can answer within a certain time with the amount of resources you have. You do need to seek and secure ethics approvals. You cannot just pick patients' data up or pick up samples or just start asking people questions. You've got to go through the ethical approval processes. That's how people get into trouble. Ask your research and development unit, does my study need an ethical approval? If they say no, you need to say that in your publication. Try and find pockets of money for funding. There are lots of research councils and people who want to do studies, even collaboratively with African institutions and in the West. They're all there. You need a strong institution. These are things that people will look at before they give you funding. Are you part of a strong institution? Do you have a track record of research? Are your supervisors committed? What is your dedication like? You should have contingency plans in place for what if I can't recruit the 100 patients that I said. Then what am I going to do? You need to try and collaborate with people and with centers. You guys are privileged. There's a whole world out there. There's a virtual world out there. The researchers, your geography cannot limit you. There are people who are willing to collaborate with you all over the world, and you just need to find them. Utilize a statistician to analyze your data. Speak to a statistician before you start collecting data, and try and make sure you report your findings and publish. It's been a pleasure chatting with you. We've got a couple questions which will be put on the quiz at the end, but I'll stop at this point and ask if you've got any questions.
Thank you very much, Dejo. That was wonderful. That's brilliant.
Thank you.
Any questions, please? Can you, if you're not asking question, can you switch off your microphone? We're hearing some background noise. Okay, there's a hand raised. Constantine Ezeme. Ask a question, unmute.
Okay, thank you very much for the lecture. I really appreciate it. My question is for beginners who have no profile in research. How do one go about getting collaboration when you've had no track record in research? Thank you.
Okay, well, thank you very much, Constantine, for that question. I think you'll find that Mr. Adedeji is going to answer that question with his talk. So you can start with simple things, audits. They're simple things that you can at least start with and, measure that, decide what your question is, measure it against a certain standard, analyze your data, present it, go over any quality improvements that you can see in your department and publish it. So audits, you can start with audits. There's collaborative work that you guys can do together. You don't need any, on this screen alone, you've got a very strong UCH collaborative. You can club together and you can start doing collaboratives together. Certainly when I trained in the West Midlands, we had a West Midlands collaborative of trainees. And what we did was, whether it's the orthopods or the ENT guys, we would meet maybe once a month. We'll talk about all our research ideas. And the important thing was that we started gathering data amongst ourselves. We worked in different parts, different hospitals, but if what we're looking for is hemorrhage, post-tonsillectomy bleed, for example, we ask Constantine to tell us how many tonsillectomies were done in our hospital and how many post-op bleeds. We ask if Oladejo to do the same in his hospital. We ask Olaleye to do the same. And suddenly we have not just 5-10 patients, we have 200, 500, and that becomes a strong paper to publish. So audits, collaboration, speak to your, you have research active consultants that you can speak to. If they're not research active, they've probably done a lot of surgery, and you can say, look, Oga, I can look at your data. We can retrospectively look at what you've been doing. You can find people in the universities. You can just Google whatever it is you need. Someone is interested in a particular genetic profile or whatever, they'll have their profile online. And if you email them and say, look, we're interested in doing this in Ibadan, suddenly you get openings. So I think you just need to start small.
Okay, Abiola.
Many thanks, sir, for the lecture. Mine is actually a bit of an extrapolation of the lecture. Following clinical audits, and there may be medical panel being set up or medical litigations, looking at the level of evidence. I just want to ask, why are we still using expert opinion in the court of law or in medical panels when it is actually is at the lowest level of evidence? And especially in instances where there are a lot of researches that have been done with the matter of the issue at hand. So why are we still using expert opinion despite the fact that it's at the lower level of evidence? Thank you, sir.
Thanks for your question, Abiola. I think there are a few things there which I'll try and sort of tease out. Now, medical legal practices is a whole different ballgame to medical research level evidence, which helps to inform, give you some sort of evidence base on whether you should do a procedure or put a drain or do this, or bring a patient back in a week or 2 weeks. So those are sort of slightly different things. And when you talk about medical legal evidence, the experts they refer to there are people who are probably the leading lights in that field, and therefore they can provide an opinion. There is something about what your peers think about what you've done. If you've done something wrong, they're going to ask, if you're a general surgeon, they might ask another general surgeon who has a similar sort of practice and has done enough similar procedures to comment and say, has Abiola done this the right way? Is this the standard of practice? But increasingly, it goes far beyond just your peers or the standard of practice. The level has changed to whether it's a reasonable thing for the patients to expect as well. So I think when you're talking about medical legal evidence, it's slightly different. Now, sometimes the case in point may have to do with a field of practice that there are not many people who practice it or have evidence on it. It might not be something common. It might be a particular genetic thing, or I'm a robotic surgeon, for example. There are not many robotic surgeons. It might be so narrow that you have to go get another specialist who's done all that they've done is a few hundred of these things rather than thousands. So I get that expert evidence is low level. Whenever you come across expert evidence when you're trying to treat patients, you could aim for something higher. I'm not going to start putting drains in my thyroidectomies because Professor Abiola says that that's how he does it. I'm going to look at, what's the meta-analysis for putting or not putting drains post-thyroidectomy that's published by Cochrane, for example. And when I see those two levels of evidence, I go with the higher one. So it's just meant to inform you. But when you don't have any higher evidence and all that you have is someone, just a single person in the world who's done something, then it becomes expert level.
Okay, thank you very much. I think that just to add to what Mr. Olaleye said is that I think they're totally two different things when you're talking about experts in court, and the criteria that they use in court are totally different from that. But a medical expert that goes into the court is going to depend on medical evidence or what research evidence is. But the question usually in front of a court is not really about the evidence as such. It's more about what have you done that a reasonable group of people would accept is the right practice. So it's totally two different things. Before we go on to, there's somebody who's written something up. Before we go into that, Oladejo Adepoju has had his or her hands up for some time. Oladejo Adepoju.
Thank you very much, Mr. Olaleye, for the presentation.
My pleasure.
My question is about meta-analysis. Do I have to be an authority in a field to write a systematic review and meta-analysis on the subject? And on a lighter note, I just want to say a very big thank you for this opportunity. I happen to be in the UK at the moment. I'm a senior registrar in surgery. I'm doing a clinical rotation in the UK. I had a chat with a colleague recently, and when he found I was Nigerian, he mentioned it. And I proudly told him we graduated from the same university, and he had very effusive words for you as to how a clinician you are and how exemplary he found you as a leader. And we just consider this a privilege.
No, thank you so much.
I have a few more questions on clinical audits. I don't know if I should wait for Mr. Adedeji's presentation first, or if I should have questions now.
Yeah, you might want to wait. But thank you so much, Dr. Adepoju, for your very kind words. I think it's important to be consistent wherever we are, whether we're at home or abroad. And I think that what we do also impacts on the next generation coming after us. And we all need to be mindful of that as Nigerians and as ambassadors for UCH wherever we are. So yeah, I'm grateful for the kind words from your colleague. Now, in terms of your question, no, you do not need to be an expert to do a meta-analysis, but you then become an expert when you do one. You just need to find a well-defined question and 2 or 3 reviewers. And then you just go through. You decide what databases you want to review, whether it's PubMed, Embase, whatever it is, and what your keywords are. And you get all your abstracts out. You screen the abstracts. 2 of you screen the abstracts, and then you pick the papers that you want. And once you've done that, then you start data extraction, data collection. And then put it through stats and publish it. As long as it is done in a systematic fashion and it's repeatable and the results can be validated by an external source, you don't need to have done one before. But the moment you start doing systematic reviews and meta-analysis, people start quoting your work, and you then at that point you become the expert at the top of the tree. So it's just the way it is. I did a systematic review for my PhD as well. I was trying to look at human papillomavirus and how it causes tonsil cancer, but I wanted to understand what the prevalence of HPV was in the oral cavity. So I had to start from HPV as broad keywords, put in tonsil cancer, put in infection, all these papers, 6,000 or whatever it came out. Then I had to start sitting down with another colleague, and in the end ended up with about 45 papers I could merge together. And then I could then look at, is it different in Africa compared to Europe, and then you could do whatever. So yeah, you just need a few of your colleagues on the screen here, and you're good to go.
Thank you.
Okay, thank you very much. I think the last question would be, this is a bit general. I don't know where you can read it from your chart, by Portia Osuji. Article publication is a challenge from African countries due to the problems of standardization of data. Can you read it?
Yes, so I can. So thank you, Portia Osuji, for your questions about on article publication and the challenges that we all have, particularly in Africa, because you don't have your.
Can we say that please, Alabiku can you mute, please?
Oh yeah, thank you. So data standardization makes the whatever you put into the paper, the quality of the data you put into it will determine the quality of the paper. There's no way around it, and that's why whatever data you want to put in, try and quality assure it as much as you can. If it's retrospective data and you've got missing data, then it becomes a problem. So if you can set up prospective studies, it strengthens your hand. And so you're absolutely correct. So poor record keeping in institutions, you can't find the data anywhere. It's either you do prospective work or you try and get things from people's logbooks. Your surgical seniors might have a list of all the cases X that they've done, and then you can then try and pull it out that way. Cost of publication, yes, that is a challenge, because more and more journals are asking for some money to publish. And when you're starting out, you might want to look at journals that don't require publication fees. There are some, depending on what you want to publish, a case report. I started off as a registrar at your level, publishing case reports. The journals didn't require money, and then they started asking for some stipend. But there are still journals that will publish your content free. There are journals that will, part of the Inari group, that will publish your content either at a cheaper price or free because you're from an African institution. They're graded A, B, C, and they would ask you when you submit. There are journals who you can write to and they can waive that. But look for journals that you don't have to. I would not encourage you to start wanting to go and pay for publication. It will cost you an arm and a leg. Just because you want a publication, a journal asks you to bring £750, for example. Yes, you get published, but you'd also you go bankrupt if you do that too many times. So there are journals out there that will not charge a fee. There are journals that will publish for conferences. You can write to editors. And the IMSG also has its own journal, which Mr. Adedeji has been driving forward, the Journal of Global Medicine. So we're keen to get publications out from you guys as well, quality work, and I think we'll be looking at it so the costs are not onerous, or I don't want to say they are free. I'll let Mr. Adedeji say that, but we certainly want to encourage you guys to publish, and we have an IMSG journal which you can submit to as well. So yeah, a lot of challenges, but that should not deter you. If anything, because you've got something unique here. There's just very limited data coming out of Africa, and you guys are the future, and you can correct that.
Okay, thank you very much, Dejo. That was excellent presentation and very good questions that you have. Before I go on to my part of audit, I'll probably just add to 1 or 2 things about that. In terms of quality of what you can publish at any level. I had my first publication as an SHO, so that was my second year of 3rd year of graduation when I was in this country, and I actually wrote a review article now as an SHO as well on duodenal cancer. So I wasn't an expert on duodenal cancer, and what do I know? But you only know by reviewing the literature, getting good data. So I think I can't remember how long ago I published this. It was back in 1990 something that I published that. So you can all of do that. In terms of publications from Africa, there's a problem. 2 problems. One, you alluded to the quality of data. Quality of data matters a lot. A lot of the times you're publishing in journals that are international, so that the overriding thing is that what is my message? What can I take home? That's we're talking about the editors. What can I take home from that? So even now saying, oh, I've got 5 cases of, say, roundworms causing small bowel obstruction. 1, 5 cases doesn't tell anybody anything anymore. 2, is it relevant? But if it came and said, look, we've got 1,000 cases of roundworms causing small bowel obstruction right across Nigeria or something like that, it has a message of, 1, it's a big study. You can learn a lot of that. So if you have a direct question that you want, the quality of the job. Today, it's difficult to publish a case report. It will be extremely difficult to publish a case report unless you have an overriding message in that. And that's the point. It has to be quality, and it has to be, as Mr. Olaleye has referred to, there has to be integrity in your data that you're publishing, and that it can withstand scrutiny. And that's the most important part for all of that. Yes, I think we'll go on to that. So I'll go to talking about audit, and I'm going to share my screen. Share screen.
I think Mr. Hussein has his hands up.
Oh, sorry.
Funshaw?
Yes.
Just one thing. I mean, I agree with what you've said. There are 2 bits to research, I think. One is the ability to do research. The other second is the ability to write.
Yeah.
Okay, because what you write actually makes a great deal of difference. Even though you may have an excellent question that you've answered very well, but the ability to write is sometimes difficult. I would say anybody start publish. I published first paper in Dokita when I was in UCH. That was my first go-out publication. Do that. Write something locally, and then and then after that you go on national and internationally. But it gives you an ability to practice writing, and that's important.
And I think that's a totally fair point, Sakif. Thank you for that. Okay, we'll go on now to audit. Can we mute microphones again? Can you all see my page? Yep.
Yes, sir.
Okay, good. So I'm talking to you about audits. I'm consultant, colorectal surgeon at University Hospital Durham, and I've been a consultant for, good Lord, it's going to be 20 years this year. I'm just trying to get rid of this thing that's blocking my view. Audit is quality improvement. Mr. Olaleye has been talking about what research is all about, but I think what is important to a clinical practice is actually our audit more than a clinical research. It is a quality improvement process that seeks to improve patient care and outcomes through a systematic review against explicit criteria and implementation of change. That's how the National Institute of Clinical Excellence describes it. And my objective in this talk today is to tell you and to convince you that it is crucial to good clinical governance. Now, two things. You have been, thank you for those of you who have answered the audit survey. It's still open, and therefore it means that unfortunately I won't discuss that part today for the simple reason I don't want to bias the people who haven't submitted. And as Mr. Olaleye has already spoken to you, the reason why I can't discuss that, I think it's only 25 or 26 of you who've answered, and we've got about 73 of you who signed on to this body, and you can really understand that, one, that would be poor quality if we wanted to take any meaningful thing out of what most of you have not done. And I think that there are, for those who have answered it, there really are some wonderful things that I think in itself is open to ideas that you might want to do and look at as a bigger study, but we'll go on. So what to audit? What do you audit? You want to audit the structure, how things are. When you have an emergency, who sees the patient? Who determines what's going to happen to the patient? Who's going to operate and at what time? Who are the people on call at any given time? What structures do you have in process? What about the processes? And I'll allude to a lot of this as we go along. What are the processes? When the patient comes to casualty, when do you go? When do you have to go? Once you've gone, when you decide to operate, what are the things that has to get in place? Those are all the things that are possible to audit, and you need to audit this in order to get your practice going. And then obviously the most important part is that you need to audit the outcome of your care. Who can audit? Individuals can audit. You can work as a team, your department auditing what you all do, or at service level. Your hospital wants an audit, and those are all the important people who can take part in audit. I've got a slightly simpler thing, next slide, but this big slide shows you this is from NICE guidelines. The most important part is at 12 o'clock. What are you trying to? Oh, good Lord. Can you hear me? Okay. What are you trying to achieve? You go to what the whole point about. So what are you trying to achieve is you look at the guidelines. You have national guidelines, what the evidence is, if you don't have a national guidelines, what the consensus is. So evidence from literature, what the consensus is, and what are the common outcomes. You go to 3 o'clock, are we achieving it? And that is the purpose of audit. Are we achieving what we're meant to achieve? You collect data, you need to find sampling, and that you, how many patients are you going to look at? What time interval are we going to look at? When are we going to do that? And then you design a questionnaire that's going to answer, like putting all of this. And if you're not achieving it, you obviously need to know why. So when you do your question, and I'll allude to this a little bit later, when you do your questionnaire, you want to put down into your question the things that you need to admit, but what the possible problems are why you're not achieving these things. Now, what is that important? Once you've done your audit, you need to present it to people, to your colleagues, and we have a monthly mortality and morbidity meeting. And with this monthly mortality and morbidity meeting, we present audits. Audits that have been done need to be presented to people. And then you decide that once we've presented this audit, these are our findings, what can we do to change that? And you decide what you need to do to change that, you implement it, and after a time of implementation, you then re-audit it, which gets you to 9 o'clock, which says, have we made things better? So the important part about audit is that you don't stop after you found the problem. You've got to do something about the problem in order and implement it, and then re-auditing yourself. And that's how you close the circle of audit. And this is a simpler version of the previous slide, which is essentially, again, identify the issues you have, define or obtain the standards. In United Kingdom, we have quite a mature auditing, national auditing processes. Almost everything that we do has been audited or is being audited, and I'll show you. And those are the standards that you work by. You collect your data, and then you compare your performance with standards, implement change, and I'll show you a good example later on, then re-audit, and then identify more problem. And this is meant to be a continuous thing. It's meant to be a continuous thing that you know what you're doing. And if I just sort of have a break there, is that you cannot have, and can you say you have a world standard medical practice without the benefit of audit. Within the circle, which I've already alluded to, you need to establish what the best practice is, measure against that, take action to improve, and you need to monitor and sustain improvement. Clinical governance. What's clinical governance? As this is defined by the United Kingdom, is that the framework through health organizations are accountable for continuously improving, a continuously improvement of the quality of the services and safeguarding high standards of care. And this is done by creating an environment which excellence in clinical care is flourish. I don't think anybody can disagree that we need to continually improve the quality of our services to our patients, and that we have to safeguard high standards of care. And if you look at the next slide, that what are the principal areas of achieving clinical governance? These are the 7 pillars of clinical governance. Clinical effectiveness of your practice. Am I not killing as many patients? Well, am I killing too many patients? And you have to remember that in this country, we've had things like Bristol investigations, Stafford investigations because of high mortality, and obviously research that Mr. Olaleye has spoken about. But the crucial part of all of this is clinical audit. You cannot find out what you're doing without auditing what you're doing. The other part, obviously, risk management, education and training, patient experience and involvement. I'll go a bit on that education and training. I think education and training is important because there's so many things that we think we know that we don't know. There's so many things that we're comfortable with, but are wrong. And many of us, there's so many people who become consultants, and that's the last that they pick up a book. Or people who are not continually, things are changing, and that's where education comes in. And that has changed your practice and patient experience. And I'll allude that in some of the answers you've given to my survey. Patient experience and involvement, and Mr. Olaleye already spoke about that. Information and IT. Information is part. A lot of the time now, I do letters for my patients. I have diagnosed diverticular disease, and they get a leaflet about what diverticular disease is. They're coming for colonoscopy, they get a leaflet where they're coming from. So they're informed about the processes as we go on. What is important, obviously, is that what's the difference between myself and Mr. Olaleye, what we're talking about. Let's take postoperative pain. I have added at the beginning of this, is that what's the difference between audit and research? I have taken at the beginning of this service evaluation. The reason I put that on, obviously, is that you can't evaluate service, but is it audit? But let's look at the postoperative pain. When you are doing a service evaluation, you ask the patient to complete a questionnaire about how well they think their postoperative pain was managed. You're evaluating your service. It can be an audit if there's a standard that 60 or 70% of people have to be happy, then it becomes an audit. And part of our evaluation is that we do appraisals every year, and in a 5-year cycle of revalidation by the GMC, we have to evaluate a service by patients. So I have to send questionnaires to 25 of my patients. Sorry, let me rephrase that. I don't send the questionnaires to 25 of my patients. The nurses send the questionnaires to 25 of my patients, and they have to fill this out. That am I a good surgeon? Would they? And part of the question is that, would you come back and see me? And would you ask a relative? Would you allow a relative of yours? Would you advise a relative of yours to see him? So that's a service evaluation. However, in postoperative pain, if we want to figure out, if we want to do an audit, then the audit is comparing the postoperative pain management practices. So what we're saying is that after colorectal surgery, when you give the patient pain, they should not be in pain, and their pain score should not be more than 3. And if it goes to 5, not more than once in an 8-hour cycle, something like that. So you're having standards that's measured nationally, and then you can say, we'll look at 100 patients who've had laparotomy. How many of them fulfilled those criteria? That is an audit. And of course, in postoperative pain, even now saying, using paracetamol and ibuprofen versus IV morphine, which is more effective, that's research, because you are dividing patients into groups and trying one drug on one group and comparing to placebo. That's research. And most important thing about research is that you obviously need ethical approval, and for most of them you need funding, and you need to recruit patients into this. And I think I'll sort of allude onto that again in my next slide. Okay, so audits do not involve new treatment. You're evaluating against standards. It does not involve additional therapies on investigation. You're not doing anything. You're looking at what you already have, or you're prospectively auditing and what you do. It doesn't involve allocation, which I referred to in my in the last slide, and doesn't involve randomization. I think we need to be very careful. That's not what audit is about. So, do you need ethical approval? I have to say you don't need ethical approval for your audit. So when you want to do an audit, these are the questions you need to ask yourself to make sure that you don't need ethical approval. Does this study involve a new treatment? No, then no. So if you answer yes to any of this question, then you need an ethical approval and you're moving away from one audit is. Does it involve additional therapy? It should not. Do I need to allocate patients? It should not. And does this study involve randomization? No, it should not. Now, just going back to number 3, obviously, if you audit 100 patients who have postoperative pain, you might say within your audit that you know that you are in an area, and I am in an area of high drug abusers, and I operated on a woman on Monday, and last Monday just gone, who has abused morphine all her life. So if you wanted to break them into groups of how they respond, with auditing how they responded to pain postoperatively, you might decide in the subgroup that those who are known drug abusers and unknown drug abusers. But that's a different thing, because that's more that you have not changed anything that's on there, but it's more about what you have, and you're using characteristic of the patient to do that. And there's the other part that's a bit woolly. Is there any other reason why the steering group think advice should be sought? And they may have reasons for wanting to that, but none readily comes to mind at the moment. In my hospital, and I think in most hospitals, if you want to, there's a central area where the hospital controls all audits. So anything you're going to do, research, audit, anything, you need to inform the appropriate authority. And in my hospital, all audits have to be registered. They have to be registered. One, they want to ensure that it is audit and not research, and it's not service development. And these are two separate things. And then they decide that you don't need ethics, you can go ahead with the research. They usually ask for over what period, and you're going to do that. And you need to do that. And after you finish the audit, you need to submit the audits to them. You need to submit the audits to them. But the most important part of any audit, you need to share it. It doesn't have to be published. It doesn't get to publication level. Whatever audit you do needs to be shared to your department and by everybody to the managers, so they can know outcomes, so they can learn from you if there's anything to take out of it. Well, whether you're doing very well, it's obviously good. So the important part, you need to share your audit. But if you do very good audit, you can have presentation at national and international level, and I'll come to that a wee bit. If your audit shows that there are problems within your practice, in your hospital, then you need to decide, how can we deal with that? Put the measures in place, give yourself time, and then re-audit it. It doesn't have to be you that re-audits it. It might just be that you've done your 2 years and somebody else comes in to re-audit, or you put something in place, as it were, and you need to maintain the practice. At what level do we do audits? I have referred to earlier, national level, regional, hospital, individual and groups, and personal. And I'll just touch a few of those as I walk. So these are national audits, and we have the most important audits, and I think when all this really started at the national level, was a national confidential inquiry into perioperative deaths. This started in 1988 in United Kingdom, and it published its first report in 1990. And what it did was, over a whole year, up and across United Kingdom, they collected data on all patients having operations. And for some time, we used to get a yearly publication, which runs into hundreds of pages that comes in. And one of the things they found is that we need dedicated emergency lists, and which today they're all called CPOD lists, that we don't need to operate at midnight on patients. You've been there all day, that you put patients' life at risk when you operate at midnight, and that you need to operate only if the patient's life is at risk or the limbs are at risk. So we're really saying that something that that can wait. A lot of things can wait. And that's one of the things that's CPOD, as I started up, CPOD was 4 at the time and became National Confidential Inquiry CPOD. And it's made a huge difference on surgical practice in this country. And also part of that is that senior consultants or consultants have to be present if the patient is unwell. They have to be in theater. Not only surgeons, but anesthetists have to be in theater when patient is being operated on, even if they're not the ones actually doing the operation, but most of the time they do that. And then from the success of the NCPOD, it has morphed, and I'll show you some of, briefly some of that, what they've done, is morphed into all specialties now. And we have a national body that routinely does audits. The current one, which is a progression from CPOD, is a NILA, which currently started in 2012 and has a 10-year life. If it doesn't have more money, it goes on into 2022. So at the moment, there's a national emergency laparotomy audit. And what we have is that every patient who's undergoing emergency laparotomy, you can see up there, Royal College of Anesthetists, Royal College of Surgeons of England, and Intensive Care National Audit and Research Center. And this has been funded by the government as well, centrally. And they are collecting data about, look at the organization and what happens about what patient care that goes on, and they want to drive quality improvement. It's looking at the structure, the process, and the risk-adjusted outcome measures. Then the risk-adjusted outcome measure is different from CPOD. CPOD looked at everybody at the time, but this is including risk adjustment for all the patients. So we do, we use a NILA questionnaire before we operate on every patient. In my hospital, we have a NILA lead, and I think we'll come to that. For you to, when you're going to do audits, particularly when it's collaborative, you need a structure. So we have a NILA lead whose job, and she's paid for it as part of a clinical duty, is to ensure that every patient undergoing emergency operation has a NILA, fills an online NILA form, and it's all data is inputted onto the national NILA and depository for everybody. I'm not quite sure if this would work, but let me just see. And then every patient, can you see the page that I've set up, put on? Can you also see this page?
Yes, we can.
Okay,
Yes,
good.
sir.
Yes.
Okay, good. So this is called the NILA risk calculator. And every patient who's undergoing emergency surgery has this filled for them. Every patient, and it doesn't matter much, all it says, name, this, ESA score, and you have sodium, potassium, urea, not that much, hemoglobin, serum, pulse, blood pressure, Glasgow scale, and then things about the state of health, respiratory, cardiac, ECG, what type of operation they're going to have, and then blood loss, what you've got in the tummy, and that. And that generates a mortality risk for the patient. Now, just forgive me, I'm trying to get back to my slides now. Okay, that generates, I'll keep on talking while I'm trying to get to my slides. That generates a risk for the patient. Okay, just bear with me for a moment. I'll stop sharing so I can minimize my screen and get that back on. Okay, can you all see that now?
Yes.
Yeah, okay. Okay, so that generates a mortality risk, and I'll come to that. What the lead ensures, and I think the reason I'm going about is that you need a structure that's that not only do we have a lead that has to ensure that all these data are inputted, we also have a a care of the elderly physicians, because a lot of our patients are older, a care of the elderly physicians who is alerted for patients who have a high mortality rate. So he takes part in the post-operative management. Part of the job of the lead is that has now mandated that we cannot book a patient for theater for emergency if we've not started inputting our data on the list. And if they, after you finish your operating, if you don't complete that form, you get another email from the lead to say you haven't completed your form. And NILA releases on an annual basis how hospitals right above the country have done and how much they've fulfilled with that. Now, the importance about NILA is not just the process that we're doing. The other thing they're auditing is if the mortality is greater than 5%, so they've put a number to it, we have to have the consultants in theater, and that's audited. So how many hospitals have consultants in theater at the time, but also that they have to go to critical care. And they audit that, how many people have gone to critical care for this. Both of this measured above. What I've written, obviously down below on that slide is, can anybody see a possible audit within the context of this? And I will come back, just keep that in mind and think about it. And I'll ask a question at the end of the talk, is that in your environment, we'll have to agree some limited resources for looking after patients having emergency laparotomy, and the fact that a lot of patients have to fund the treatment. Can you see what possible audit you can do? And we'll come to that at the end of this. Now, what I did, it is a busy slide. I don't want you to go through all of this, but as told you before that the audit for perioperative, post-operative outcome that was published in 1990 started as a surgical thing, was morphed into a national thing now, and almost all specialties are being looked into. And these are some of them year on year on. I'm just reading some of them, from tracheostomy, from lower limb amputation, to sickle cell disease. And all these things have been audited, and all these audits are done on a national, at a national level. So what have we achieved from this national audit that we have? One of the things that we've achieved is that we now know that patients who have been admitted as emergency, as urgent, that's across all specialties, they have to be seen by the consultant as soon as possible and at least within 14 hours after admission. So the days that you have registrars doing the ward round and consultants coming around twice a week has gone totally, because the whole idea is that you have to see patients every day. And that includes Saturday and Sundays. So we now have, in my specialty, either the consultant on call sees all patients, and that can be really onerous, or in some specialties, another consultant comes in to see patients who's not on call and would have to go in. I think Mr. Adedeji is on somewhere here, and I think that's what they do in the hospital. I don't know, Mr. Adedeji or somewhere. That's what they do, consultant who's not on call, and that's part of NILA. Part of NILA, part of the national audit is also that we need some forms that people have filled, early warning scores. Almost all our patients only have an early warning score. And along with this early warning score, it's not just you put the numbers down there, you have to have numbers which you escalate, who you escalate to, when you escalate. And these are all things that are auditable. The most important part is to do with consent. Okay, this part, obviously, I have to confess to you that I'm not sure that it's followed that way. But the whole idea is that when you want to consent a patient, it's got to be a two-stage procedure. What are you consenting a patient for on the day of operation? We all consent patients on the day of operation. Many of them are terrified. And having been a patient who's had surgery, I can assure you, you don't listen to what anybody's talking to you on the day of the operation. You can't remember. So it's meant to be a two-stage thing. Consent them in clinic. When they come in, remind them what they've done. But the important part is that you need to tell them what the risk and benefits of the procedure is, including the risk of death. And that should be clearly described, and also the risk of not having anything done. And these are all things that can easily be auditable. And should write this clearly down. And back to the gentleman who was asking about law, if any of these things don't happen, by the way, you don't have any leg to stand on in court, and the consent process should not be undertaken in one stage on the day of operation. So that's the most important thing. That it shouldn't be taken in one stage. You can't put it all to them. This is, you may die if I do this. You may not die if you don't have this when they're already in hospital. All that needs to be discussed before patients come in. Now, looking at national audits. So that's national, that's at the national level, that's the governmental level. But we have audits in my coloproctology Association of Coloproctology. They also collect all the data, and we send that data for cancer operations. And this is our cancer operation. Myself and my colleagues, I'm somewhere down. This is a bit of an old one, which I just really sought for. So I had 67 patients. But there's a central area. And what you have on here in terms of audit is that the red ones are all of us in my hospital. The blue ones are all colorectal surgeons across the United Kingdom. And we get this data every single year, and it's online. So anybody can go there, click my name or click your surgeon's name, have a look at the data, and that's the importance of data, and it drives quality improvement. Now, one of the questions in the audit that you guys have been filling, the survey that you've been filling, which I said I'm not going to share until more people, until I get a near majority of you signing up. This is my personal audit.
Thank you.
I became a consultant in 2001.
Thank you.
I became a consultant in 2001. Oh, sorry, I became a consultant in 2001. And in 2001, I decided that I was going to collect all my data as a consultant and everything I did. So I have now worked in, I'm in my third hospital that I'm working on. Can we just all mute our microphones, please? That I'm going to collect data. And so I started from when I was in Sunderland using Excel and Access database. And that's a bit, I designed Access database from the word go. By the time I left Sunderland, about 2.5 years later, I had over 900 patients there. Then when I got to Birmingham, I continued using the same Access database. But the difference was, one of the things I found out from my audit, obviously, is that if you're having minor or intermediate operations, you don't die. Okay, the complications we don't know because they've gone home. So I stopped collecting data, and because the numbers were just too many, I stopped collecting data on minor and intermediate and collected on all my majors operation cancer when I was in Birmingham. Then when I moved to Durham 2.5 years ago, I went from Access is a difficult program to use, to Excel spreadsheets. And this is it is on there, it says 30th of December, but actually it's up to now, and you can see there. So month to month, what I've done, in green, total number, and blue, elective, red, emergency, length of stay. For the length of stay, I need to use complex major and major, okay, for elective and for major. And I have data onto March, I just haven't put them on that. But this data is 99.9% accurate in terms of the number of patients and my complications, and I'll go to that on that. And the reason I brought this up is because obviously some of you in the survey that I put on the site did say part of the audit you want to do is personal audit, and I think that's something that all of you should do. Okay, I can tell you that I know how good I am, and I know what I need to change, but I have my data that goes on to 20 years. Okay, so I know so over this year, over this last 2.5 years in Durham, I've done close to 500 now. So I've got a few more to add to that and what I have there. So there's a page in Excel spreadsheet. It's all there. All this I calculated, so I don't need to do that all the time. And then this is a very busy slide, but the whole point about audit, I just spoke to you about NILA. So for all my patients, my data spreadsheet is huge. For all my patients, they have a NILA mortality calculated. So I know the NILA mortality, and I do P-POSSUM because NILA is for emergency and P-POSSUM is selective and emergency. And it gives a number of major and complex major operations that I've done. It tells you my mortality. So I know what the national mortality is amongst my colleague. I know what my mortality is. I know the NILA says that my mortality for patients is half of what you'll expect from the risk patient that I'm operating on. I know my infection rate because I collect all complications as well. Now, obviously, as Mr. Olaleye alluded to, if the biases or whatever problems you have in such data, you need to do so. I could say that I have, I know all my wound infection rate and mortality, but obviously, if they go home before they develop this may not get there. When they come back to clinic, if I see them, I retrospectively record them, but the ones that are discharged, then they may get missing. But for the most important one, they're there. Tells you how many operations, what is elective, tells you my colonoscopy. So in the 2 years in Durham, I've done 142. I've done, I go to the CCOM in 94, so I complete 94%. And the standard for this country is 90%. That's the standard you're meant to achieve. So I know that. And while I've told you this is over 20 years, I actually have data on my colonoscopy for 25 years. complications rate. And one of the things I record as well is when I'm in theater with my trainees, how many times do I scrub with them? And that's recorded. So it's very busy. These are my laparoscopic work that I do. It's very busy, but I don't see any reason. I was going to ask you guys how many of you have logbooks, which are fairly important part of training. So how do you do an audit? You need a topic. You need a topic. It needs to be specific. It needs to be directed. It needs to address for audit, address where you think there might be a problem. And then once you've chosen an audit, do you want to do it by yourself or do you want to join with somebody else? You need a team. Then you need to set the aim, the objective, and the standards you're looking at. Ethics and engagement, I think that's important bit. I think obviously here you're not asking patients, if you're going to use, say, for example, their pictures, obviously, then you need to obviously get a consent. You need to make sure the data is accurate. You need to make sure it contains everybody's work and not just yours. And as I said to you, that my audit of my work is 99.9% accurate. Okay, because anything less than that, you're just involved in self-deceit. Okay, and you need to, what are you auditing? Are we auditing over a month of people that came? Are we auditing something that's, or are we looking back 5 years? Okay, it's a retrospective thing, and then you carry out your data, you analyze your data, and I've spoken to that. You present your findings. Now, I put this online, and I put this online for you to read. But I put it on here mainly not because my name is on this publication, which is an audit, but because the two people, Michaela Cameron and Stacey Jones, they're the foundation year 2 doctors, so that's the second year after graduation. But that's when they published this. I was just sitting in my office when they were 4th year medical students, and they came to my office. Mr. A, we're looking for a supervisor. We need to do a project. We want to audit something. And that's what they're looking at. The whole concept of this audit were by 2 4th year medical students. They collected data across 3 hospitals. So it's really the postings. They'll collect this data. And then they decided that not only, because there was standards for antibiotic use, prophylactic antibiotic standards, we have standards for almost all operations in general surgery. So not only that, is that they saw that we were failing, and they decided to do a questionnaire survey of consultants. So consultants, registrars, surgery, and anesthetics. Let me just reemphasize, and that's why I'm so proud of this paper. Let me just reemphasize that there were 2 medical students in their 4th year. And they did this across the 4th and 5th year. And they collected the data. So we found out that, yes, a prophylactic antibiotic, we're not following guidelines. Hospital had guidelines of their own, and they weren't actually following the guidelines that they were. And that's what the first audit came across. So the point about the audit is that they found that they're not following guidelines. So what do we do? And this is what they did. So we then designed this poster. And this was designed by the students with the microbiology department. This is 2012. So we're talking about now 2012. So they were about 2011, 11 that we're talking about now. This getting on to 10 years now. They designed this poster, and that's the part that you implement. And all these posters went on the wall in anesthetic rooms and in theater. And it was pleasant when I operate, seeing people looking at these posters developed by my medical students for use. And then it was obviously re-audited, and it was re-audited. Now, just going back to the questionnaire, to the person who asked a question earlier about quality. If this had gone to publication after the first audit, it would never have been published. But the reason for the publication was the fact that there was a change that was implemented and it was re-audited and it showed an improvement. And I have to say that since I think it's published in 2015, this has been cited in so many other papers. But do not forget that these were two medical students. They're both, unfortunately for me, one of them went to ENT and the other went to medicine. None of them is doing proctology because I think they were both fantastic students to have done this. I'll quickly talk on collaborative. I think the whole point about audit is that you can't have single person audit, but I have left this on. And you can understand that audit done by one person is usually small, individual units. It might be that it's at the consultant of that unit that is poor. And then the West Midlands trainees, which Mr. Olaleye was one of them, in 2007 decided that they wanted to join together as registrars to collaborate. And they have done, I think I have put on, one of the, I put a chapter, I didn't put a paper, and they've published so many papers now of collaboration across the whole region on antibiotics, on wound sepsis. And I think that's a place that you guys really need to look at. But the important part, just as with NILA and as with collaboration, you need a structure. You need a structure, you need a committee, and it's later. This last 3 slides are in the chapter that I put on the site for you guys to look at. Okay, but you have a steering committee, you have lead collaborators, you had advisors, and I think that part of the reason the 2 surveys at the top of the audit one that I've put there is more to see what type of people you are. Okay, because I think that when you're working in collaboration and you're trying to get something published, who you work with matters, and how you go about this does matter quite a bit. And then you obviously have a writing group, operations group, and obviously I think Shakif, Mr. Hussein obviously mentioned about the quality of the people who write that. So it might be everybody, somebody will collect data, somebody is doing this, but there's some people who are good at putting this down into words. So it's just finding and working to everybody's strength. And then you have at the bottom end, what else you can do. This relates to both audits and research, by the way. So they have done audits and they have also done research, and I think, and that's the important part that you can do as a group. So I think this is probably the last slide I have. What leads to successful collaboration? And I think it's the important part is that you need to have a leadership. You need to have somebody driving it. You need to have somebody driving it. And I think that if you have somebody driving it, and if you've chosen somebody who is driving it, and I think everybody has a responsibility to listen to them. When you have people who drive things, they can be annoying. Okay, they can be annoying because they might just be disturbing you when you don't really listen, want to talk to it. But that's the point. That's the point, and that's why they're the drivers. And I think you have to have a cohesive team. And I think the other parts are very well established communication and decision-making process, and foster cohesive spirit. And I think that once you start publishing things, you start getting things done, you all have the benefit from that. And I think that there are quite a few papers and they have now been published by the West Midlands Collaborative. And the West Midlands Collaborative has led to many collaboratives in the Northwest, in the East Midlands, all across the country. And there are collaboratives working. Thank you. Do we have any questions?
May I make a comment while people are digesting?
Yes, go for it, Banji.
Thank you very much, Funcho. Excellent overview of a very comprehensive subject. I suppose the point I wanted to make, I was quite touched by seeing your personal series, and I think this is a very, very useful and important little thing. I'm sure the people in the audience saw what I also typed out earlier as a very simple and doable clinical audit project. And audit can be as simple or as complex as you like. And of course, it's always good in medical business to start simple. I was touched by your personal series, which was very useful. I opened my own surgical series over just under 20 years as a consultant, and there's about 5,000 different operations on that. But that's not the point really. I wanted to draw out. I looked just at my own personal CV, and I can see at least 6 peer-reviewed articles as a result of audits. Not mainly because I was very fortunate to be doing relatively new things earlier on. So these audits, such as they were able to be publishable. But that's not, again, the point I wanted to make. What I did, I was a consultant. I would have as Funcho has just pointed out, I would have a junior doctor who will sit down. I would just give them, I don't know, laparoscopic pyeloplasty. I'll give them my ex-patients on my personal database of laparoscopic pyeloplasty, and they will put it together, look at the hospital records, get it together, and then upon review, they would present it locally, and depending on whether or not it had significant merit, it might then go on to a publication. But either way, that is how audit happens. And I'm suggesting as well that any one of you, if you find a consultant or that you are particularly have a rapport with, again, that's how it starts. Approach them and have some ideas of your own about what you might be able to audit, but obviously interact with them and get ideas about how to progress the matter. It's always a win-win situation for everyone if it's done right. Thanks.
Okay, thank you very much, Banji. That's a wonderful addition to what I've said. I've got Olaleye Adepoju's hand up.
Thank you very much, Mr. Adedeji, for the presentation. It's unfortunate those 2 chaps decided not to do surgery, but I'm sure you have gained many more.
Oh, sorry, one of them is doing surgeries. Well, he's treating the surgery. It's called ENT, but
Okay.
No, the other one is she's an ENT trainee.
Lovely. But you've gained many more. I happen to be one of those who have inspired to choose this specialty. Sometime in 2010 or 2011, I'm not very sure, after one of the IMS meetings, I and a few other colleagues had a quick chat with you in Polendrixie Lecture Theatre, and you said a few things that consolidated our decision to choose this specialty. Thank you very much. A few questions. Number one, how does one prevent finger pointing when you're presenting audit findings? What I mean by that is, okay, let me give an example. Maybe this will help to clarify my question. I have a friend in orthopedics who did an audit recently on the use of bone grafts. And they typically use allografts, which they have decellularized and sterilized. And they just realized that they didn't take consent from the patients specifically for the use of those allografts, because they felt they were just, the grafts were just offering structural support rather than them being seen as a biological tissue. And so there was a controversy as to if this should be seen as something as important as a kidney transplant when they use these grafts. Of course, this was widely practiced in the trust, and nobody took special consent to use those bone grafts, and they were allografts. And so he did an audit, he had the support of his consultant, and he presented this at the clinical governance. And then it became a big issue because a lot of people felt they were pointing fingers at them for not instituting that. So how does one prevent this sort of thing, giving an impression that you're pointing fingers. The other question that looks like that is, if one did an audit and someone is found to be at fault. We did one recently where we audited post-operative VTA prophylaxis for patients who've had major colonic resections for malignancies. I'm sure you're very aware that the recommendation is 28 days of dalteparin. And there were 2 patients who were not on DUAC and were not prescribed dalteparin for some reason. And so the question there was it the SHO that did the TTOs, or was it the anticoagulant nurse, or was it the GP that didn't follow up on it and all that? So there was an inquiry set up and they identified where the fault was. How does one do this sort of audits and make sure that there is no negative ripple effect on the person who was responsible? My third question is, this is specifically about colorectal surgery. I've just been given an assignment recently by my educational supervisor, who happens to be a colorectal surgeon, to write up the CATME projects that the hospital has done in the last couple of years. The Norwegian registry published last year in BGS, led to the ACP-GBI to give a positional statement that this procedure should be suspended for now because of all the cases of local recurrence. Now, my question is, if I'm writing this up, because we have very small sample size, just 11 cases, I don't think this is going to be a publication, so to speak. If I'm writing this up as an audit, what do you suggest could be the standard I could compare with? Can I use the UK National Registry, or should I use the International Registry? That's one. 2, what factors can I look at that will make it reasonable, considering the fact that the sample size is quite small? And then the last question is, for those of us who want to do some of these audits back home, one major challenge we are going to face is that there is no designated clinical lead for audits in the hospital. I mean, it's quite straightforward if we wanted to do this in the UK, because there is someone that is designated as clinical audit lead or clinical audit manager, from whom one can get information about which audits have been done recently, which ones have been done at the moment, so you don't repeat those same things. And the person can advise on how one can go about it. We don't have such a person in our hospital usage. How do we circumvent this challenge of not having a clinical lead managing audit projects? Thank you very much.
Okay, well, thank you very much. God, you have to remember I'm getting older, so I have short-term memory, but I'll get to that. And thank you very much for the kind words at the beginning. The first 2 ones that you spoke about, that's the allograft and the audit, are 2 separate things. And in the very first one, there's an issue of consent. Okay, and I think that we have gone through the trauma of doctors doing things that they don't have patient-specific concern. And that's a specific issue. I'm not quite sure why that's an audit, and that's not a bit of a problem. I think that something that's come out from that is that if you're doing things with patients, you're not consenting, and you're not consenting them for, it's a clinical governance issue, that the hospital will do that. And I think that even if that came, let's say, for example, you want to publish that, it's one of those things that the editor would want to know what the patient consented if you do that. And if they want, then I think that's a clinical governance issue. I don't think that's an audit thing. The other part of audit is that audit is not about fault finding. Audit is about improving, is about improving practice. And the enoxaparin, yes, we all have to give 28 days on that. And we have audited it in our hospital as well. And we have also seen that not all patients, I think now it's much better. It's not about finding fault with anybody, okay? They may want to find out why it happened. Oh, it's because the discharge letters have not been done properly, or there's not a column for it. And now these days that everything has gone online, they could say, well, if we put a form there online and that you cannot close the form until you've marked a site that have prescribed enoxaparin, then that's a reason to find out who's done it. The place that I would object to, if they then say we've got to sanction them, that's an objection. You can't sanction people unless they've also done something that's criminal, like the first case. So those are those two. Now, with regards to the TAPMI, there's so much that's been published with TAPMI, okay? And that's 11 cases becomes more of a case series than an audit, okay? And for me, I'll have to say there must be an important message that you want to get and that you want to get out in your 11 patients, okay, that you are, and particularly because of the position statement by the ACP GPI. So even if, let's say for argument's sake, that he's done 11 cases and there's been no recurrence, you know, that's not statistically valid. Because if the recurrence rate is 4%, to 4% of 11 is even less than 1. Okay, so it's not a valid study in the sense that it doesn't have the number size. Okay, so as a study, it's not a number size. And as an audit, I wouldn't really go down the route of the audit part with this. So I don't think, I mean, for me, I don't see the purpose of 11 patients. Okay, there's no need to audit with that. Now, to your last part of the question, which is in Nigeria, everything changes. Everything changes because the younger one push it. Okay, as I've said to you, and I keep on teasing all of you, that there are important things that have come up from the survey that you guys, all the 3 surveys, that you guys have been filling. And as the last time I checked, I think it was only 23 of you. And because there's 73 of you who signed up, I think we probably need close to 60 people, if not more than 60 people, to fill that and to make a relevant thing. And I think it's important because you're all trainees, and this is the time that you guys should be falling over and killing yourself trying to do these things. And you guys have to drive it. And I think the data from the survey that I have from you, one of the things I thought was that, look, because of the data from the survey that I have from the people who filled it, is that it's something that you can actually say, somebody would lead it, that we've got, this is what UCH residents have said, can we do this on a national level? I'm taking it that there's an association of resident doctors in surgery in Nigeria. Can we do this on a national level? And if we do this on a national level, if the findings are similar to what we have, then we can say, how can we work on that to improve that? With a number that big, you can then say we want to work on heads of medical schools or teaching schools, that we need to do audits, we need a structure. And as I alluded to with your collaboration, you need a structure. And I think that, I think that Joe and everybody, when we all met you initially, and we're all sort of keen on supporting audit, and I think we're still keen, and I'll share some of the things that you guys have written on soon now, after asking all these questions, share some of the things. The only part of the audit that I'll share with you is some of the things, and I think that a lot of you actually have good ideas in the survey about what to do, but it's more about sitting down, doing them, seeing what your records are, how accurate these things are, finding out what you can do, but working as a collaboration. And what you really need is that you guys need to sit down and say, we're going to form a collaborative group. Let's do some audits together. And again, if you do audits together, you all share the things, and what can we audit? And that's how it starts. Okay, so I think that until you start having a mass, and I would definitely say that once I've got enough people who've done this audit, I'll share it with you, but I would encourage some of you to sort of take it on, and let's do the audit across all surgical residents in Nigeria or most of the teaching hospitals, mainly resident doctors, and see what the national thing is, and you have a voice. You will have enough big enough thing to publish, but also have a voice as to these are the things you can do to answer those questions. And that's my response to that.
Funso, thank you. I just wanted to add a little bit to the very important question that Dr. Adedeji raised. And you made a very important point that audit is not about naming and shaming. So the audit presentation, the audit discussion is never about any personality discussion. Of course, there's a place for it, and that is probably a place for maybe an individual clinical supervisor to sit down with an individual doctor to talk about a subject on a one-to-one basis. But in the context of the audit presentation, it's never. Otherwise, that culture of audit will be stifled. And again, it's up to us, all of you, all of us gathered here. You are the next generation to alter, change that for the better. That's all. I just wanted to really emphasize that point. And well done to you, Dr. Adedeji.
Thank you very much.
Yes, thank you very much, Banji. And I think that's also a very important point. I mean, it's not about blame games. Mr. Olaleye.
Thank you very much, Mr. Adedeji, for your excellent talk on audit. I was also particularly struck by your robust audit on your own procedures, and I think for all of us as surgeons, it is certainly something to aspire to keep a record of all that we do and complications. So thank you for that. I just wanted to give a few suggestions to all our residents on the sort of audits, because some of you may be overwhelmed by all this talk, particularly with all the challenges you face in the environment you are, and thinking, how do we even begin here? So I've written about 9-10 different things that you can do, and those they're really sort of simple, straightforward things that you can get going with. So the first thing is a self-audit. Okay, you can write this down. So you could do a self-audit, and you can pick one procedure, whether it's appendicectomy, or hernia repair, thyroid surgery, laparotomy, even if it's all the laparotomies you've been involved in, and you want to audit the ones where you've either been the surgeon who's been supervised, or your trainer is unscrubbed, or you're performing it with another junior. Just a self-audit. So look, since I started residency training, I've done, 50 appendicectomies. How many had any postoperative complications? How many went home the same day? So you just need to, so self-audit is the first thing you can easily do. The second thing is you can look at the adequacy of consent, which we've talked about. Now, in every surgical institution, there are consent forms. You could do it retrospectively. You can pick a specific procedure, consent for whatever. Go find everyone who's had that procedure in the last whatever timeline you want, and just check basic things. Was the date on the consent form? Was the procedure clear? Were alternatives explained to the patient? Were the complications all listed? What was the grade of the person signing? So very basic things like that. And all you might come out with would be, oh, I've audited the adequacy of our consenting process, and 80% of our surgeons sign and date and put their names. So you've got another 20% that can improve. Or you're not actually listing the risks. That's a big problem. So you already have set standards. You don't need to reinvent the wheel with that sort of very simple, basic thing. And it would improve the quality of care you provide in the departments. Another thing which Mr. Adedeji mentioned is record keeping. It's very simple. Record keeping for wherever, admission or day surgery or emergency admission, the date, the time, the person taking the records, how adequate is their record keeping? Again, it's very straightforward and it's easy to do. And then it's an audit. Emergency operations, you can audit that from I don't know, 5 p.m. till 8 a.m. the next day. Are we actually doing emergency operations in that time, or is it only life or limb operations? It's very, very basic, simple data to get from the theater logbook. Who's been coming in the last 2-3 months? Were they all emergencies, or are we doing elective cases in the middle of the night? And you might trigger a culture change that way. The WHO checklist, number 5, WHO checklists. I hope that we use this in Ibadan as well, but this is now sort of almost a global thing. Everybody stops at the start of surgery to say, what site of operation, what operation is it? Have we got blood ready if we need it? All that sort of stuff. And it's easy for you to audit that because, you've got a retrospective paper trail that you can go back and say, I looked at all our, admissions or surgery cases in the last month, and 50% of the time we didn't fill the WHO checklist. Straightforward improvement in the department. Everybody starts doing it. Sepsis bundle, very straightforward. There are predefined things that need to happen when a patient comes in sepsis, the blood samples that are taken, antibiotics are started within 6 hours, all this other stuff. You can easily go back and say, well, we had 100 cases of sepsis in the last year. How closely adherent to these guidelines were we as a department? I've got VTE prophylaxis here. Right? Some of you would know, sadly, we've lost even one of us, a doctor recently, to what sounds to me like probably deep venous thrombosis from a tibial fracture. So just look at VTE prophylaxis for some of your major cases. Are we following the guidelines already there? You're measuring your practice to the set guidelines. And then you present that at your department and you say, look, we're 70% compliant with prescribing VTE prophylaxis when patients come in. Can we improve? You re-audit it again in another 2 or 3 months and you're now 95% compliance. That has helped your department and gives you the audit you need. I'll now go on to sort of collaborative working. Surveys are a very, very straightforward, easy thing that you can do. You're an online generation. You can set up surveys on SurveyMonkey and send it to across all the residents in UCH or in Nigeria, even if you wanted a national appeal on any kind of surgical topic. You might not get everybody respond back, but you will at least you'd have done a survey that can answer a specific question. Think about the collaborative that Mr. Adedeji has been talking about. On this screen alone, you got like 40 of the residents. I don't know if you're on a WhatsApp group or not, or whether you guys are already collaborating. But in the UK, we're all on WhatsApp groups. It's so easy to say, hey, okay, we're all on this group. What do we need to do? Can we look at one, impact of COVID in hospitalized patients, for example? And every one of you just finds out, which patients have been admitted with COVID in the last year. How many of them were admitted to the intensive care units? Suddenly you have hundreds, you've got data, and it's just on the click of a phone because you're on a WhatsApp group or something. I don't know if you're not, I would strongly suggest that you should. The same thing should help with the national sort of paper or collaboration. The UCH residents should be on some sort of platform with your colleagues across the country, and suddenly you have a national collaboration to answer questions. I think the final thing I wanted to say is you can start small. The very first paper I published in Dokita, which is a UCH journal, and it was when I did my rotation in Erua, the community health rotation with in Erua in those days, Ibarapa. And I just looked at the mortality, the sort of admissions and mortality trends and things like that. And that was the very first paper that I published. So it is possible. I'll reiterate what Mr. Adedeji also said about a number of your audits transform into papers. If you do good audits and you re-audit it and you do show a quality improvement, it is publishable. There are journals who just want to publish quality improvement initiatives as well. So yes, I'd really, really encourage you to think about the little things. Start with the little things, the self-audits, the consent, the record keeping, emergency operations, WHO checklists. The last time we spoke with your cohort, there were at least 88% who had not done a single audit. And I think that we're hopeful that, you know, by November, we would have transformed that number, just because you would have done basic, simple things, at least an audit. And those are my humble suggestions.
Okay, thank you. I just want to read from Portia Osuji. In clinical audits, how can adverse outcomes impact on trainees be mitigated? In incident reporting, in order to encourage honest reporting and better learning curve, disclosure briefs, psychotherapy to help strengthen coping mechanisms and deal with self-imposed guilt. Okay. I think that obviously, if I go by UK practice, there's not a single of my trainees, and from my data that I showed you, I'm always there anyway, and there's not a single of my trainees who, if they have problems that I wouldn't know about. And we work in so many hospitals that everybody would know about that. So it's not about that. And I think that there's a part of the concept of how you put the narrative is that we're all going to make mistakes. We're all going to make terrible mistakes. And the important part is, do we learn from the mistakes? Do we improve what we do? And I think that's the first thing that we're going to do. And as one of my colleagues would say, if you tell anybody you don't have complications, then you've not operated enough. So we all get complications, but it's that we learn from it, and it's not a persistent thing. So I think that one of the things, sort of going again through what Portia is writing there, is that it comes from a bit of, and I have been a program director, and many trainees say, oh my God, I can't do an anterior resection. I'm first year trainee. Oh, sorry, I was about to swear there. You can't do an anterior resection in your first year, 6 months. Okay, it takes a number of years to get there. But I think it's just the same thing, that I can predict to everybody on here that you will make a mistake and you will make a big cock up at some point. But the most important thing is, one, that these things do happen, but that you learn from it, and that you have sort of help with that. The disclosure part, I think you have to disclose everything, and you have to disclose everything you do. And in this country, we now have duty of candor. And the duty of candor is that if you do something that is puts the patient at risk, and it's been identified, you have to go to the patient and tell them, I have done this and I put you at risk. So it's upfront. So I think you cannot hide from that. But I think that the difference we have with a patient in the United Kingdom compared to United States is that it's not a litigious society. Okay, it's not a litigious society as it is in the United States. And a lot of patients, if you're upfront with them, okay, they are willing to forgive. And I think that's the way that you have to look at that. The disclosure process, so psychotherapy to help strengthen coping mechanisms and deal with self-imposed guilt. That's a bit of a difficult one. But one thing I have to say about self-imposed guilt is that you do feel guilty. And I think that surgery, unlike medicine, on medicine, you have a heart attack. You come in, and the physician comes in, intervenes. If you survive, great. If you don't survive, it may have contributed to it because you didn't do anything they should have done, but it's more an act of omission. Whereas in surgery, and I think that's the important part, we sometimes pick people who are well. Say you have cancer in your bowel, you're well when you come in. You just got cancer, we treat you. And if you have a complication that's serious, either life-threatening or gives a huge morbidity, of course, there's a sense of, well, what did I do wrong? What should I have done? And I think that that's a difficult one to do, in the sense that there's a guilt. There's always a guilt. Okay, and I think that if I would confess, I operated on a woman. She's 50 something. She's got a benign tumor in her bottom, in her rectum. I did a laparoscopic thing, took the tumor out, but she had complications that get her into this state left her in hospital for almost 6 months before she was. Yes, something that I felt guilty. It was a well patient with a benign tumor, and that I took 6 months out of her life. But I think that what we really need to understand is that that's occupational hazard. I'm not sure that psychotherapy is something that is quite common, and I don't really have experience of that. But I do know that obviously, being program director, yes, that we do have people who sometimes do struggle, and I have sent at least 2 of my trainees for psychological help when they have this. I hope that briefly answers your question. Mr. Oluwale?
Yeah, good evening. I haven't been on these before, but I'll just pass my own comments. I'm one of the ENT consultants in Sheffield. What did you mention? I thought I just mentioned one point. I'm not sure if you mentioned record keeping, because that would be a key, easy one to do, to go back into records. Was the date put in the right place? Was it timed? The person signed for what he was doing? That sort of thing. It's so easy to do a retrospective audit for that. The other thing I was going to say is the concern about the culture in Nigeria, where it's the blame culture and fear of the boss saying, well, don't bring out any audit that shows me in bad light. Well, pick one that's uncontroversial initially, where you don't necessarily have to give the name of the person. It's just a question of who didn't put his name down. Not who didn't put his name down, someone didn't put his name down. So there's, in terms of filling in notes, take something that's less controversial. Having said that, looking forwards in 5 years' time, my emphasis would be, it's for you guys now, as the new guys, to then get in there as seniors and say, the culture is meant to be non-blame. Therefore, please come and audit my work. And then set an example to other colleagues who haven't yet imbibed that concept. And that's the way to take it forward. Otherwise, we'll forever be faced with this idea of people not wanting to have themselves shown up. You have to grab the bull by the horns, lead by example, and get an audit on your own work and put it in the right lights. I hesitated to say this, but I'll mention it. For example, I had an SUI, which is a serious unwanted incident, and it's about due diligence. The minute the thing happened, I was straight on to the patient. It's basically a question of, normally I do both sides first. I mean, Dejo will know this. There was one of them where you're meant to do one side. And if I had seen the patient in clinic, I would have booked that patient for both sides. As it turns out, I did the right side. Well, let me rephrase that. I did the right, as in right, left, only to realize near the end I should have done left. I did a septoplasty, then I did the wrong side, let's say, and then I went back and thinking it was, but then I realized right at the end. No one else would have noticed. I mean, it might have come up later on. And the way I handled it, and I wasn't proud of that. If that was a year ago, about 2 weeks ago, for the first time ever in my 38 years of practice, I'd done that sort of thing. But it's the way I handled it, the due diligence, the fact that people understood. I beat myself over the head much more than anyone else. And I've sat at meetings whereby it's been discussed, but you're open about it. It's not about blame culture. The question there becomes, what could we have done differently? Did I do all the WHO processes of left, right? We did all that. Everything was done spot on. But I still managed to do, inverted commas, the wrong side. As it is, I just sort of unscrubbed, took 5 minutes, went back and did the correct side. Immediately we finished, we went and explained to the patient. I mitigated it by saying I would have done both sides, but that's not the point. So it's about humility with these things. And rather than taking it as blame and finger pointing, I pointed the finger at myself much more than anyone else did. So it's about the environment, and no one's blamed me. The issue is more, what can we do to make it not happen again? We did the WHO, we did the pause, pre-op and all that. So all I've said with that is, well, maybe what we should be doing is doing a pause in the middle of the operation. Say, right, now I've done the septum, I'm going to do the left side. Some people are saying, well, we don't need another pause. Well, that's up to them. At least I'm saying we should improve things. So it's about putting yourself in that position whereby you are taking control rather than worrying about what others will say against you. I agree it's a cultural change. And that's why I go back to my first point, which is, yes, pick up a non-controversial audit initially, if you're worried about that. And then subsequently, when you become the seniors, be the ones to blaze the trail and say, right, let's start auditing ourselves. I've made my point.
Okay, thank you very much, Funsho. That was a very wonderful thing to say. And I think I echo again, what Michelle has just said.
On that note, I mean, I needn't have said that, for example. I need to have mentioned that case to people I don't know. But it's about being open, and that's the key thing.
Yeah, I think that from sure, and that's what I said earlier, that duty of candor is there. Don't worry about whether everybody would know what you've done if everything goes on. But what I need to read to you is what Dr. Adeboye has written. I think you've all read it. And that's going back to what Portia said earlier on. Without feeling guilty for an error means you've lost your humanity and possibly should not be practicing medicine. And it goes back to the same thing, that I think that mistakes do happen and you will feel guilty about it. But that's just part of being human. Now, what I'll do, I can see that Mr. Olaleye has posted a few audit projects, but what I want to share with you on the screen is actually some of the things that you guys have wrote. God, I'm speaking like a northern, a British northern. You guys have wrote. One of the things that you guys have written on the survey I sent to you, if I can find the survey. Yes. So this is only part of the survey that I'm going to show to you. Okay, and the things that you guys have written, I asked you if you want to do an audit, what do you want to do? Personal audits, and I think one or two people wrote that, and I think the personal audit is essentially what I do, and I think there's absolutely no question. You should all have a logbook. And I think your logbook should not stop when you stop being resident. You should have a logbook until you retire of what you're doing, how well you're doing, and most important part, you need to be honest about it. Okay. The other thing you've written is perioperative protocol in ENT department during COVID pandemic. The important part about audit, this is audit, you guys, I'll show the research bit now. This is audit we're talking about. You always need to have a standard that you're comparing to. Are you comparing to the normal standard, or are you comparing to COVID period, which is undoubted, there might not be things, but that's a bit difficult thing to do. But somebody's written outcome in emergency surgeries. And I think that completely fills into NILA outcome. Okay. And one of the questions I asked before, when I said that, do you find out with NILA what you guys can go to your environment? We know that patients have to pay. Many patients have to pay for their care. We know that you probably don't have as many critical beds as possible, but we have that standards that now says 5% of patients who with mortality of 5% should have a consultant. You can audit that. Who is in theater when you, so let's just say you want to do a prospective audit, that for the next few weeks, you want to fill the form, NILA form, for every patient that come in and record their outcome for the next few weeks. You want to do that, and you want to record the outcome. And two things, you want to know what the outcome is, but those who have NILA outcome of mortality of 5%, how many of those patients are have consultants in theater? Consultant, surgeon, and consultant instance have to be both of them. And for those who don't go to critical care, because that's what you're going to have, what was the outcome in them? Okay, and you have a standard that obviously is going on with the UK. I don't think it's a world standard, but that's it. So you can compare to that. And you have this again, somebody audit of cystoscopy is done in the division. You have to look for what you're doing, for what you want to audit about. But these are things that these are the people, these are you guys have put all this down. Outcome of pediatric long bone fracture, managed conservatively. Okay, so I mean, I'm not an orthopedic surgeon, but you then have to find out that how many should you manage conservatively? Are you reaching standard in terms of treatment care? What standard are you comparing it to? And yes, what the outcome is. So the outcome audit, I think, so you have a lot of things there, but I would suggest that you guys will probably, and we can all work on that together. You probably sit down as groups and do that. Then you have surgical outcomes of patients who had enterocutaneous fistula in my center. Oh my God, that's going to be a difficult one. I mean, that enterocutaneous fistula is going to be a difficult one unless you're a center that sees all the enterocutaneous fistula, or you have a high level of enterocutaneous fistula. And then you have discharge summary. I think somebody's speaking about that. So you have ideas here that I haven't gone through all of them to see treatment algorithms for surgical emergencies. Again, that's a useful thing. Do you actually have treatment algorithms for emergency surgical admissions? We have, okay, we are sort of falling over which protocol to follow, and everybody has protocol. And I think that for me, for what you've written in your survey, there's so many useful things that you have no ideas. You just need to be able to crystallize it and make it into something that's auditable and that people can do. Clinical outcome and patient satisfaction. Patient satisfaction comes under more likely service improvement, and there's no reason why you can't do that. Okay, all you just need to do is find a pro forma, find the questionnaire. Since a lot of people may not totally understand your grammar, you might want somebody who can speak to them and interpret it in Yoruba and let them feel what is going on. Practice of what do you call this? Universal precautions among frontline health workers. So there's so many ideas you have and all of that. And I think what we'll probably work moving forward, as Mr. Olaleye said to you, I'll stop sharing this for a moment. As Mr. Olaleye said to you, we're hoping that we can move on to at least 60–70% of you doing audits this year. Then we would know that we have obviously achieved something and we want to help. And I think if you want to audit, what you guys need to do is sit down, say, what can we do as a group? Even if they're individual audits, that's fine. I just want to share something else with you before I go. Now, again, I'm going to share this with you. Where's my sharing? So what I just shown you now was audit. But again, this is what you guys were writing for research question. I asked you about research and I said, what's a research question? Now, obviously, this is an academic. Obviously, we know that. Targeting Ki-67 as a biomarker in breast cancer. Obviously, for that, you really need to speak. There are quite a lot of wonderful breast researchers from Professor Oladejo that's helping with Ibadan. It's helping Ibadan. I think, I can't remember his name now, who's in Ibadan. I think those are things. And you have research question, intra-protrusion of median lobe of prostate. Obviously, I'm not a urologist. I don't even understand whether that's in English, but you have this prostate thing. You have ideas. Okay, you need to find out looking at people who can help you with developing this. Okay, and I think that what I haven't done is I haven't quite looked at this to say what is actually research, what is audit. But I think that the Joe and myself have gone to differentiate the difference. But what I wanted to show and share with all of you is that you guys have ideas. Okay, you just need to make it work. I know your responses to why it doesn't happen. I'm not sharing that until I have a critical mass with you at the moment. Now, before I leave the site, just to say that we have loaded the lectures. My lecture, Mr. Olaleye's lecture is here, my lecture is there. And I have also now loaded a feedback form to fill for the lectures you've heard. And I'll be very grateful if you can all fill that, because it tells us what we've done well, what we've done poorly, how we can improve. And I assure you, as with all feedbacks, it's anonymous. So I'm not going to come around to punch anybody in the face. Any questions before we go? Just to say that obviously it is the feedback for all the lectures, and you're going to get similar feedback for all the lectures, that they are very important. It helps us deliver this. And I think that online teaching is something that we want to continue. We all that, so we want to continue, but for us to improve, we obviously need you guys to tell us what we've done right and what we've done poorly. And I have to say also that I'm very grateful to Fumi Shoneye. She does answer my text whenever I send a text about getting you guys to do things. And it's nice to have somebody that I can just sort of transmit or communicate with to get this going. And we hope that we can continue with this. I just have something else from Dr. Adeboye. Keep a simple Excel sheet to record all your activities. Yes, okay, so I think it's just really telling you. And I think, yes, having gone from Access database, I think that using the Excel spreadsheet is the best way. It's the best way to record all of this, and you can do an awful lot. Do we have any questions? So what the lectures are on there, and there's a quiz that's going to be, which is going to be for you to do, but the quiz is probably going to be on tomorrow, not today, but it will be there. Once it comes, I'll send an announcement to everybody. But I do implore you, please, I need over 60 of you to fill the survey, please, on the 3 surveys I have on there. And once that's all done, then I'll share the outcome with all of you. And then with the audit, we can talk about how we'll move that forward. Any more questions? Okay, well, thank you very much, everybody. It's meant to be an hour. It's 2.5 hours it's taking us. Hopefully that's one there. Thank you very much, everybody.
Thank you very much, sir.
Thank you very much, sir.
Thank you very much, sir.
You're welcome.
Thank you, sir.
Thank you very much. God bless you.
It's a pleasure. Thank you.
Tejo, thank you. And Banji, thank you. Sekif, thank you. Funsho, thank you. For joining. Helen, thank you. Kayode, thank you for your wonderful comments. And who else have I left out? Ayo is on here.
They should record it as CPD because they count CPD in Nigeria now.
Okay, that's fine. I think that they can record it as CPD, and also I think that on the website, the Moodle site, we can issue certificate because it's 2 hours. One thing I forgot is that I will put the recording online and then I'll put it on YouTube, but on a separate page, and then link it to you because I don't want to overload the Moodle website. Yes, you can record it CPD. So you get that. So what I'll do with the Moodle thing, it has competencies. So I think what I'll do is that I'll draw up some competency thing. And once you've done the quiz, I think that's what we need to look at it. So at the end of the quiz, you will get a competency thing, and then that's done. For this one, we'll make it 2 hours.
Oh, wow.
Is that fine for me?
That's fine. It's very fine, sir.
Wonderful.
Yeah. Thank you very much.
Thank you very much.
Thank you so much, everyone. The ENT specific teaching I will finalize with Mr. Yelakin, and I will most likely get Mr. Oluwole as well to help chip in. He's involved.
Yeah, and I should point out ENT surgery as well for those who regard surgery as general and refer to surgeons, and you didn't do surgery because you didn't do ENT. And I noted that.
ENT is awesome.
I didn't know you were listening, for sure.
I was
listening.
No, you rebuked him in a nice way. So to make a point, everything's surgery, not just general.
ENT is absolutely awesome.
Yeah, ENT is awesome. No, I think that it's what's it called? Michaela is a nice, wonderful addition to ENT world. I mean, she really is just a phenomenal.
Yeah. I recognize the name before you mentioned that she's gone into ENT. I recognize the name.
Yeah, and she's senior trainer in London, Dinnery.
Oh, well, catch up. Cheers. Thanks, then.
Okay, thank you very much.
Yeah.
Thank you, everyone.
From the real French show here, by the way. Yeah.
Yeah, Dejo.
Yeah.
Obviously, the site of the Moodle, you can use that for the ENT, but I need to get you editing. I can get you editing rights for that, so that you can set up the same thing.
Thank you.
Okay. I don't know how many ENT people are registered on, but we can obviously separate them out so that the ENT people can use your thing. But once you start doing it, then we'll sort that out.
No, thank you so much. And then I think we can then look at how to write a paper and publish as a separate thing.
Yes. Yeah, that's fine.
God bless you all. Keep safe.
Agomo, I don't know.